Hello, and welcome to Cutting Edge Pain Relief. Today, we're talking about medications and lack thereof by focusing on muscle pain and what are some treatment options that work best within that context. But before we get into that, we need to understand what are muscle spasms, how can they be affected, and really what has historically been main treatment options, whether they are really the right options any longer. As you saw from that picture, traditionally most people try to use non-invasive type treatment options, things like a gel or over-the-counter type ointment like a Bengay or Aspirin or something along those lines. But as we know, many times those things just don't work. Either they don't get deep enough or they're just not effective on that problem or issue. And there are a number of reasons as to why that might be the case. So when we talk about pain, particularly with that's muscular in nature, it's pretty universal. It happens to most people during the course of their lives, whether it's due to a trauma or it's due to some chronic nagging injury or just kind of longstanding wear and tear. It's been assessed and evaluated by multiple different physicians, researchers, individuals that are not within that context that deal with mobility, that deal with yoga, that deal with body functioning as a whole and traditional physical therapy. And so one of the things that we really kind of get down to is what makes a muscle. And what makes a muscle is the following. So when we look at that muscle, we can be able to see that it's comprised of bundles. And those bundles are comprised of muscle fibers. And those muscle fibers in particular have a wrapping, and that wrapping around it is something that's called fascia. And so when we look at that fascia, one of the things that we have neglected historically is to identify that it actually can be a contributing cause to our pain complaint. We historically have assumed that it's reliant almost exclusively upon the muscle having an issue and a problem. And that's not necessarily the case. When we take a look, we can see that there's a stress point that's listed in this picture. And that stress point is indicative of something that's called a quote unquote trigger point. So what is a trigger point and where does that come from? That language, all those type of things. And in order for us to talk about that, we need to go back and look historically in order to have some understanding. So historically, as we can see from this little blurb, it was originally brought forth in the mid 1900s, where it was listed by three different individuals: Gustein in Germany, Kelly in Australia, and Kellergren in Britain. And one of the things that they did was they injected saline of a certain type into various different structures. As I mentioned, muscle, tendon, and fascia. And what they were able to see is there were certain zones that referred pain that were close to where that injection was done, and some areas that were further from where those injections were done. And so in the United States, there was an incredibly well-known physician named Janet Travell, who began to really work on myofascial pain and figure out what's going on with trigger points. And she, along with Rensler, were the first to coin the term myofascial trigger point in the 1950s. And so they actually produced one of the most seminal or kind of like fancy key books of that time and still to this day that focuses on looking at muscle type pains. And so one of those books is the following. So you can see Travell and Simon's Myofascial Pain and Dysfunction. It's 2 volumes. It's pretty extensive. That has a number of different references that many individuals that are healthcare practitioners or focus on mobility and other elements really look at as a resource. So what does all that mean? So what all that means is the following. When you take a look and you look at a muscle, one of the things that we look at is whether there's some kind of component of a trigger point complex. And so trigger point complex is an alteration or change in the muscle that then has a resulting element of pain. When we look at it in the context of the body, one of the things that we see is the following, is that if you take a look, you can see that on the right-hand side is a little bit of a legend that says that X is the actual trigger point, meaning the muscle that has that alteration. And then the pink square or pink coloration is where the referred pain is. So you very well may have trigger points like as this representation in the trapezius, and then you have pain that surrounds it. And it's not just at that point alone. If you look at the elements of this back portion, you very well may have pain that's present in these muscles here because of the trigger point, but where you feel it is in the front portion of the trunk. Same thing for the gluteus minimus, which is a muscle that's associated with the context of the hip, where your actual problem is higher up, but then you have problems that are present in the lateral thigh and calf. So when you think about that and you think about muscle spasms and you think about pain that's present that might be aching and gnawing that you're traditionally trying to treat with medication, and then say, how can we get to the root of the problem and issue? It's much broader than that because the muscles are interconnected, as I mentioned before, with that context of something that's called fascia. And that fascia piece that wraps around these muscle bundles are actually pretty significant, even when you start looking at some of the molecular evaluations and studies. Historically, traditional physicians have grouped all muscular complaints all together, whether we have talked about myofascial pain syndromes, whether we have certain autoimmune disorders, whether we talk about fibromyalgia, but there are distinctions among them. So if we were to take a look and we compared them, a myofascial pain syndrome has a number of localized trigger points versus traditional fibromyalgia, which is more generalized and are more numerous in nature. It's more localized for myofascial pain, as I kind of showed you earlier, while fibromyalgia is much more diffuse. It's generalized. It's throughout multiple different muscles. Myofascial pain is more frequent in different spots, while fibromyalgia is less frequent. Fatigue is more common in fibro. Poor sleep is more common in fibro. Burning, prickling, or tingling is more common in fibro. Headaches, irritable bowel, and sensation of swelling also all more common in fibromyalgia. So what does all this mean? Does it mean that those two are completely different in terms of how you treat them? Potentially, yes. And so historically, when we talk about treating muscular type elements, immediately when I talk to patients about it, one of the things that they mention is, well, what about a muscle relaxer? So let's kind of address that right off the bat. So when we look at muscle relaxers, these are some of the common names for muscle relaxants, right? So you have things like Soma, Flexeril, Robaxin, Norflex, Xanaflex, Klonopin, Valium, Baclofen. All these medicines have their own fancy names that are associated with them, which are their traditional generic names. And so when we look at those medicines, what we need to look at is what do they do well, and what are some of the things they don't do well, and what are the side effects that are associated with them. Because as we know, medications, for the most part, traditionally have one little piece that comes along as an anchor that just gives us problems and issues and doesn't necessarily let us be able to take full advantage of why they might be able to help. Let's break down the categories in which these muscle relaxants might actually exist, and then talk a little bit more about what we might be able to use in lieu of them. So when we look at the categories, there's two different splits. One is an antispasmodic, and one is an antispastic or spasmolytic, if you would. And so the one deals with more blocking of the nerves and nerves from signaling in the brain, and the other blocks from signaling from the spinal cord. So one is more dealing with peripheral issues, and the other is dealing with upper motor. So you're going to see this kind of split out in just a little bit. But traditionally, the things that are going to deal with upper motor, which are more kind of higher centers, like it's going towards the brain, are going to be things that have an issue with MS, like multiple sclerosis, spinal cord injury, stroke, cerebral palsy, versus traditional injury and trauma, which is probably way more prevalent. So when we look at the medications that fall into that split, let's look at that antispasmodic versus antispastic. So if you can see this, what we're looking at right now are medications that are like our traditional muscle relaxers. So they're using the generic name. So you can see that they're mainly for acute muscle pain. And one of the things that is present is that these are antispasmodics. And so they kind of give us an explanation of what is happening with them, right? And the issues that are problems that can occur. So with this type of medicine, you just can't stop it abruptly. With these type of medicines, it can cause you some problems with your liver. It's rare, but not that common. With this, you can have something that's called serotonin syndrome. With this medication, you also can have the same type of thing. With this, it has some pretty prominent sedation that's associated with it. And with this, it has issues, particularly if you have a history of glaucoma. So all these medicines sort of fit here, meaning they actually have a connection, are one and the same, right? As we take a look at other medicines besides that spasmodic, we can be able to take a look at medicines that have that spasticity type piece. So you can see baclofen as a potential treatment option. This is mainly for CNS. And there's not really much indication for lower back pain, but not only are many physicians prescribing it, it's also sometimes recommended by certain insurers as a recommendation as a first-line type therapy. But it does have some issues, particularly because it shouldn't be historically utilized for an extensive period of time. You also can use some medications that fit kind of in that benzodiazepine and other sort of mixed treatment options. The issues and problems with those are, as you can kind of see, that increased risk of mortality, as well as issues with kidney function and how it can be able to affect it. So with all this, what we know is medications are not without having their problems and issues. So what are some of the other treatment options that could potentially be able to provide us benefit? Well, one of those options is something that's called dry needling. It fits within that Travell commentary back from the 1950s. And most people would say, dry needling, is that like acupuncture? Well, in a way, a little bit it is. So let's kind of show you a pictorial representation of what that means. So if you take a look, you can see that there's a pinch of the skin, and that pinch of the skin shows you how you're able to kind of isolate for the muscle. And then you pick a small needle and you basically place it within that area that we believe is the trigger point. There are different ways to tell whether it's a trigger point or not. And as you can see, this needle is unattached, just similar to an acupuncture needle, a small, thin gauge. As an aside, for those of you who want depth and detail about this in particular in terms of the technique and how the two compare, take a look at our recent video that was released earlier this week comparing acupuncture versus dry needling. But as we kind of get into this, one of the things that you can see is that just by that needle placement alone, the intent is to try to be able to improve that muscular function and the pain that's associated with it. So many people would say, well, Dr. Landrum, how does that do that when you're not injecting anything into it? And there's been a number of different studies, including Travell's works, that focused on, well, when you place it there, it causes this release. And that band that was previously taught that we referred to earlier, that was suggested here, becomes less inflamed, it doesn't have the same problems and issues, and it improves. Well, given that there's been close to about 70 years of thought that has occurred since, now we know that there may be some other reasons and rationale for why this might be a little bit different. So we have an idea that when we take a look at the muscle, that muscle has a connection to the spinal nerve root that innervates the areas of that muscle. So by innervate, meaning the nerves come down and it touches to that muscle and it allows for communication both forward and back. Well, before we get up to the brain, and actually before we get to the spinal cord, there's an area that's in that nerve root that's close to the spinal cord that's called the dorsal root ganglion. It acts like little mini brains of the nerves. And when we look at those dorsal root ganglia, they have way more information than what we have originally surmised. They actually control many things so that the spinal cord and the brain don't have to worry about it. And when we look at that dorsal root ganglion, if we can find ways to be able to have it be calmer, less talkative, if you would, it can help our pain on across multiple different channels. So there's been studies that have looked at, well, are there things that can be able to influence and affect that DRG? And when we take a look, there are papers like this. So this paper is actually a paper that was published in the Scandinavian literature that looks at a different type of injectate. So here in the States, normally what we use for trigger point injections are going to traditionally be local anesthetic. Most of the time, maybe 70, 80% of the time, it's a lidocaine type derivative. Thereafter, some individuals will use Marcaine, some individuals use Procaine, Prolicaine, Prilocaine, and different local anesthetics. Sometimes it's combined with a local anesthetic and steroid. And many of those things are not without having some degree of issue because although it's probably one of the simplest procedures, it can cause tissue damage, it can cause fat loss, and it can cause other issues. So you really have to kind of pay attention. And that's fat loss locally at the site, not in general, for those of you who are thinking in a different way. Anyway, so this type of injectate is actually utilizing a 5-HT3, which is serotonin receptor antagonist that's utilized for other things. But what they found is, and it's a small study, but they found that they've been able to get 50% pain relief and be able to achieve that relief that has lasted for a number of weeks. Why is this significant? Well, the reason why it's significant is because you're not reliant on steroid, number one. So you have a decrease in terms of those type of potential side effects I mentioned earlier. Number two, you're not reliant on local anesthetic, and that local anesthetic traditionally is short in nature, the duration of the local anesthetic, which is normally hours. And number three, the reason why it's actually probably even more important than all of this is the way that medication works is it has the influence on that dorsal root ganglion and those nerves that are associated with it. And that's one of the things that we're looking at to say, how can we be able to figure out what provides value without us having as many side effects associated with it? So if we can avoid having to necessarily use muscle relaxants as a mainstay in terms of oral medication with their various different associated issues, maybe we can be able to do something else to provide benefit. There have been a number of studies that have looked at dry needling and acupuncture and compared it versus sham. What that means is a needle or a pressure or insertion that's not utilized in the same way to see is there a placebo effect. And there have been studies that have gone back and forth looking at this. But historically, what I've seen anecdotally is that there's a number of patients who do incredibly well with that type of treatment option, particularly in the hands of an experienced individual who's utilizing it. And why do I mention this? Because most providers, and probably more than that, many patients don't know about it. When I talk about dry needling, they're expecting a traditional pain injection type needle that's a large gauge needle. And we're using a needle like this is maybe 1/10, 1/20th the size of a needle that you would normally receive if you're having a traditional type of injection. But now we're talking about how can you be able to augment this? How can you be able to do something more than just a dry needle alone if you had to? Can you use it with electrical stimulation? And there have been studies in the past that have looked at electroacupuncture and seen whether it's of benefit, and for some people it is and some people it's not. But when we started looking at that within the conjunction, as I mentioned before, that 5-HT3 antagonist now, and other meds that are looking at how can we be able to manipulate that muscle to nerve interface and then be able to use other modalities, that's when we really start seeing some degree of benefit. So there are other studies that are out there, like this one, that looks at really what is the current state of how muscle pain can be treated. And really, as it goes into it, one of the things that it explains is the model that has historically been, oh, it's just the muscle is a potential issue. And now what we're believing is the case is that there's a connection. So maybe about the 8th line down, what you'll see is they believe trigger point dry needling is able to reduce the excitability of the central nervous system by reducing peripheral nociception, which is reducing dorsal horn neuron activity by modulating pain-related brainstem areas. So I know that that's fancy as heck. I'd pick another word, but we're trying to make sure that we're staying within means for both YouTube, Facebook, and anyone else. But at the end of the day, what it's saying is it's not just the muscle. It's bigger than that. What we know is that it's the fascia that overlies the muscle. And in addition to that, we also know that it's the neuronal component that connects to the cord that influences how those muscles actually respond. And it's one of the reasons why, if I was to really kind of speculate, why when we use muscle relaxants that aren't just that context of that one class, and we're using those that deal with kind of the upper motor neuron, why we're able to get some benefit, because it affects other areas than just at the site. And so there's now starting to be a trend that's looking at alternative type therapies that we've covered in some of our videos before. Can you use different dynamics of hot and cold, right? Historically, people have used ice for eons, right? And we still use ice right now. But if you go back to, I would say, a video we had maybe a year and a half, almost maybe 2 years or so ago, that looked at cryotherapy and how that might be able to influence muscular components. It may not be just the coldness that affects the muscle, but how it affects the neuronal communication that's associated with the muscle. When we talk about PEMF, post-electrical magnetic field, and how that influences it, it also may focus more on kind of that neuronal component. Some of the most interesting from a medicine standpoint, and if you would, sexy treatment options that are out there are those that are looking at shockwave therapy. Here in the States, we're kind of trailing behind by easily maybe 10 to 15 years or so. But in Europe, they're using shockwave on a whole host of different treatment techniques, specifically within the context of regenerative medicine, to really look at how can we be able to promote healing faster. And it's not meant to be destructive in nature. It's actually meant to be more constructive. And that shockwave piece has also been looked at to figure out how it can be able to augment the context of this muscle neuronal interface, if you would. Low-level laser has also been shown to do similar type things, and that's very dependent upon the person, on his degree of efficacy as well as duration. So when we talk about being able to deal with myofascial pain, there's a study that looked at the traditional adult and then the chronic pain patient and assessed that for the traditional adult, more than likely, they're going to have somewhere around 40% of their pain complaint is going to be muscular related, within some element of it being either muscle bundle, whether it's going to be from a fascial source. And the traditional pain patient, about 90% of pain patients have some degree of a muscular problem that's not associated with their neuronal nervous system or orthopedic kind of secondary to an arthralgia or other SI joint or facet joint. It's really dealing with the muscle. So if we're trying to be able to improve pain, and we're talking about different buckets, right? And this is a separate bucket, then if we leave this go and we don't address it, then we're not doing everything that we can to try to be able to make pain better and make people more functional. So this video has kind of given a little bit of an initial tease that talks about muscular treatment options and what are some of the things that are out there, both here in the States as well as that are kind of burgeoning in the cutting edge pieces out there in the world that are really starting to push the envelope some. If you found this video helpful, whether you're watching it now on Facebook or YouTube, please let us know that, yeah, actually I liked it, because it's useful to know what videos do you want to hear and which ones don't you want to hear. If you have additives that you're like, you know what, this worked for me from a muscle standpoint, but I'm really interested in this, let us know. I'd love for us to be able to kind of serve what your questions are by answering what are the problems and issues that you really are thinking about. So let me kind of give you some springboard kind of jump off questions. I know I have a number of patients that come to me and they say, you know what, I have a pain that's up here in my shoulder, but then I feel it in my hip. Are the two connected? I really hate asking that question, but you make me feel comfortable to be able to ask this question. How could those two be connected? Well, there's certain principles that are out there that are looking at fascial planes and how they connect. There's a certain book that's called Anatomy Trains that actually looks at those connections and how they are integrated. Maybe that might be a question that you might be interested in. If so, let me know. Or you say, hey, you know what? Why is it that cold works great for me and heat doesn't do anything, or vice versa? And I've been told, you know, this rice theory of like using rest and ice and being able to elevate, that it's no longer useful. If that's something that you're interested in, let us know. I'll be happy for us to kind of do either a live stream or a separate video to have a discussion about it. If you have muscular issues and you're like, you know what, it's kind of this gnawing, achy, just challenging type of thing, and I can't quite tell what it is and whether it's giving me a problem or not, please let us know. If you want to know about ligamentous problems and things like whether it's the iliolumbar ligament or sacrospinous ligament or interspinous ligament or things that really exist in and around that thoracodorsal fascia that exists in the back and says, you know what, I've had all my different doctors and I've had masseuse and I've had chiros and had all these different people try to figure it out, but I can pinpoint it, but they just can't get to it. And I'm thinking it might be ligamentous in nature. Let's talk to you about what might be able to be done for that. So I had a couple questions that came in while I was kind of joining on. And one of the question was, how many sessions is usually needed and how long does relief last? Again, Jesse, thank you along with Elaine for joining us. I know that you guys are really frequent viewers of our channel and supporters, and we really do appreciate you. With the context of that question, I'm gathering that you're asking in relationship to dry needling that we made reference to, not necessarily shockwave. So I'll kind of keep my response in that context. I think it depends on what the underlying condition happens to be. For a number of my patients that have bursal tendinitis type issues, have issues where they have those discrete points that we talked about before, I will send them to practitioners that are experienced and really know how to be able to use dry needling, because there's really not a downside to it. You get stuck with a needle that's way less painful than what I would normally use. And it traditionally is going to give you some degree of benefit without the side effects that you have for medicine. I think depending on your degree of flexibility, what's going on with the muscle, it sometimes can last people months for their benefit that they can get from it, but it normally doesn't happen after just one session. You traditionally have to have multiple different sessions, and it's cumulative in nature. So hopefully that answered your question, Jesse, and it may have answered some other people's questions as well. Thank you for asking it. So for those of you, who tune in to our channel, we really want to be able to help you win this battle and this fight with pain, because we do think it's a fight and it's a battle. And what we really want you to do is to be able to figure out a way to be able to punch pain in the face and get back to leading the life that you deserve. And please, by all means, tune in every Thursday to us. We're here live, 4:30 Eastern, every Thursday, answering pain questions so that you can be able to understand how to be able to win that fight. Thank you and have a great day.